Now this one is specifically for you, the 600-level medical students at Bingham University. We're going to cut through the noise and give you a really high-yield clinical review to make sure you're totally on your game for the wards.
Welcome to The Explainer. Today we're diving deep into the clinical management of some of the most common prostate disorders you're going to see. So, here's our roadmap. We'll kick things off with the absolute essentials. Then we'll tackle our two big pathologies, BPH and prostatitis. From there, we'll figure out how to tell them apart with the diagnostic workup, nail down the treatment plans, and wrap it all up with complications and the key things you just gotta remember. Let's do it.
All right, Section 1, Prostate Essentials. Before we can talk about what goes wrong, we need to understand the basics, the key anatomy, and especially the one hormone that really runs the show here.
Okay, if you're going to remember one molecule from this whole talk, make it this one, dihydrotestosterone, or DHT. Think of it as testosterone's super potent cousin. It gets converted from regular testosterone by an enzyme called 5-alpha reductase. So why do we care so much? Because DHT is the main engine driving prostate cell growth, making it public enemy number one when we talk about BPH.
So that brings us right into our first major pathology, benign prostatic hyperplasia, or BPH. You are going to see this constantly in your older male patients. It's incredibly common.
The pathway here is actually pretty straightforward. It's a clear chain of events. First, that 5-alpha reductase enzyme gets to work, converting testosterone into DHT. All that extra DHT then tells the prostate cells to multiply, what we call hyperplasia, and this happens mostly in a specific area called the transition zone. As the gland gets bigger, it starts to squeeze the urethra, which runs right through it, and that squeeze is what causes the bladder outlet obstruction and all the problems that follow.
So, what does this actually look like for the patient? Well, it presents with a classic group of symptoms we call LUTS, or lower urinary tract symptoms. We can break these down into two buckets. You've got your storage symptoms, that's the bladder getting irritated, so patients feel urgency, they have to go more frequently, and they're waking up at night. Then you have voiding symptoms, which come from the blockage itself, things like hesitancy, a weak stream, and that annoying post-void dribbling. And when you do a digital rectal exam, the DRE finding is key. A prostate that feels symmetrically big, firm, kind of rubbery, but importantly, not tender.
Okay, now let's completely switch gears. We're moving from BPH, which is a mechanical or plumbing problem, to prostatitis. And just like the name says, this is all about inflammation and infection. When we talk about what causes prostatitis, we have to split it into acute versus chronic. For acute prostatitis, it's almost always an infection. And here's the critical part. You have to think about age. In a patient under 35, you should be thinking STIs, gonorrhea, chlamydia. But in a patient over 35, the number one culprit by far is E. coli. Now for chronic prostatitis, it's a little simpler. It's usually E. coli no matter how old the patient is. So how do you tell this apart from BPH? Well, there are some major clues. First off, dysuria, that burning feeling with urination, is way more common here. In an acute case, the patient is systemically sick. They'll have a high fever, chills, and their white blood cell count will be through the roof. Chronic prostatitis is different. No fever, normal white count, but this nagging, persistent pelvic pain. And the DRE for acute prostatitis? Oh, it's unforgettable. The prostate will be exquisitely tender, warm, and feel kind of boggy. Okay, so a patient walks in with a mix of these symptoms. How do we actually put the puzzle pieces together and land on the right diagnosis?
This is really the central question that's going to drive your whole workup. You have to ask yourself, are we dealing with a plumbing problem or is this an infection?
Now this is absolute gold for your studying. Just look at the differences side by side. Systemic symptoms? None in BPH, but a huge deal in acute prostatitis. The DRE findings couldn't be more different. Firm and non-tender in BPH versus super tender and boggy in an acute infection. And of course, a positive urine culture is a slam dunk that points you straight to prostatitis. And I want to leave you with this little clinical pearl. Unlike the acute version, chronic prostatitis can be really tricky. The symptoms can be vague, they come and go, it's a true diagnostic challenge, and it's easy to mistake for other things.
So, we figured out how to tell these conditions apart. Now let's talk about what we're going to do about them. Let's get into the management plans.
For BPH, we follow a stepwise approach. We usually start with something called an alpha-1 blocker, like tamsulosin. This gives pretty quick symptom relief because it relaxes the muscles right around the bladder neck. Then, to actually shrink the prostate itself, we use a 5-alpha reductase inhibitor, like finasteride, which blocks that DHT conversion we talked about. And if all that fails, then we move to the surgical option, a TURP, to physically resect that obstructive tissue.
For prostatitis, the treatment plan is totally different.
It is all about killing the infection. Step 1 is to figure out the likely bug based on the patient's age. Step 2 is a long course of the right antibiotics. And I mean long, like 4 to 6 weeks. You need that time for the drugs to really penetrate into the prostate tissue. So for STIs, that's often ceftriaxone and doxycycline. For E. coli, you're looking at a fluoroquinolone.
All right, we're in the home stretch. Let's talk about what can go wrong if these conditions aren't managed well. And then we'll summarize the absolute must-know points.
Yeah, you definitely don't want to let these things get out of hand. If the obstruction gets bad enough, urine can back all the way up to the kidneys and cause a post-renal acute kidney injury. All that stagnant urine sitting in the bladder is also the perfect breeding ground for bacteria, leading to recurrent UTIs. And in a really bad case of acute prostatitis, that infection can wall itself off and form a very dangerous prostate abscess.
So if you remember absolutely nothing else from this entire explainer, please remember this. BPH is a plumbing problem. It's a mechanical blockage. Prostatitis is an infectious problem. Keeping that simple framework in your head will make your life so much easier on the wards when you're building your differential.
And I'll just leave you with a final question to think about. We've talked about how tough chronic prostatitis can be to pin down. So what's on the horizon? How might future diagnostics, maybe new biomarkers, or better imaging help us get a clear answer for these patients faster and ultimately improve their outcomes? Something to chew on. Thanks for tuning in.